priority. I want to thank everyone. Okay, we're starting. So good afternoon. Thank you so much for coming to the Health and Government Operations Committee, specifically the Public Health Subcommittee. We have 3 bills on the agenda today, and we are going to get started. But first, I want to thank the members for being on time. I really appreciate your time, and I hope to be efficient so that you can enjoy the rest of the afternoon. So we're going to start with House Bill 213, and our counsel for the committee is Ms. Erin Hopwood, and our technical assistant for the committee is actually Mrs. Edith Perry. So we can get started, and I'm Jocelyn Peña-Milnick. Erin, will you get started and tell us what House Bill 213 does, please? And we have already had a hearing on all these bills. Go ahead.
House Bill 213 alters the definition of health information exchange for the purposes of confidentiality of medical records. At the bill hearing, the Maryland Healthcare Commission stated that they were working with stakeholders, consumer groups, the Office of the Attorney General on altering the definition to address some of their concerns. There is a reprint that was provided that has the amendments that they've been working on since the bill hearing, and Ben Steffen is here to describe those amendments to you.
Thank you so much. Before we get to Ben Steffen, Delegate Kelly.
I would just like to thank all the stakeholders for working on this and defer to Ben Steffen. Thank you very much.
And good afternoon, Mr. Steffen. Ben, how are you?
I am well. I want to thank the committee for hearing us today. And I want to emphasize that this particular effort is an outgrowth of work that began last year in House Bill 1022 that established an integrated consent registry for all health information exchanges operating in the state. We ran into a bit of a challenge last year in the definition of what is a health information exchange, specifically debate about what the electronic health record vendors are doing, which incorporates certain health information exchange functionality within the software products themselves. So because we could not reach a consensus on that, we elected to go back and work over the session at the recommendation of Delegate Kelly. We worked and we thought we had a pretty good definition, but at the bill hearing, we understood there was still some confusion. So first off, we decided that we would really tread more closely to the federal definitions, which really envision health information exchanges being of 2 characters. One is what we kind of use in layman's term, brick and mortar health information exchanges, such as CRISP. And in addition, a second group called health information developers, which would incorporate organizations that develop largely electronic health records, and as part of that functionality would become a health information exchange because they have the capability to meet the definition and capabilities of a health information exchange. So our first amendments do make those changes. It defines a health information exchange as an individual or entity that determines, controls, or has discretion to administer any requirement, policy, or agreement that allows, enables, or requires the use of technology or services for access, exchange, or use of electronic protected healthcare information. And then it adds some additional requirements pertaining to that. And then number 2, and that is a health information technology developer certified health information of certified health information technology that develops or offers health information technology as that term is designed in federal law and has one or more voluntary certifications established by the Office of the National Coordinator for Health Information Technology. That second definition has really been the struggle that we've gone through, how best to define those types of entities. So we concluded after the hearing that the best way to do it was really to mirror as close as we possibly can how the federal government defines those in federal regulation. I think that was maybe the breakthrough point for the overall amendments. And then we also wanted to keep intact definitions of what health information exchange is not. And this is where much of the work over the interim had taken place, in that we defined health information exchange is not entities that would be considered covered entities under the federal HIPAA legislation or regulations, excuse me, including entities that represent a combination of providers, carriers, or certain business associates. Those were left intact, and we provided greater clarity on how those are defined within this bill to ensure that they are excluded. The last amendment was really clarified in the final section of the bill, what we were trying to accomplish in terms of ensuring that there were guarantees that certain prohibitions did not occur, and that applied to the department, the Health Care Commission itself, and the Health Services Cost Review Commission for using healthcare information subject to federal laws for the purposes of healthcare regulation and public health functions. That protection would enable the entities in government to use protected healthcare information for stated purposes. It also, in 2, may not prohibit the sharing of or disclosing of information that is required to be exchanged under federal law. And 3, the sharing of or disclosing of information that is required to be exchanged for the purposes of payment as defined in federal law as well. So we think that this adds clarity to this definitional bill. It is a fix-up from last session. And will allow us to clearly define who is subject to the consent registry requirements that you adopted in Senate House Bill 1022 in 2021. Happy to stop here and answer any questions.
So basically, this bill that you have in front of you is a cleanup of House Bill 1022 that we passed last year. And what you do in this bill is that you came up with a consensus with all the stakeholders on the definition of what a health information exchange is, right?
That's correct.
And what you did was you decided to use a definition that closely mirror the federal law definition, correct?
That's correct.
And then the last portion of the bill on the last page, where it says page 404, unofficial, the line 1, that is just basically clarifying what it does not, that it does not prohibit the Maryland Healthcare Commission, the Health Services Cost Review Commission from using the health information, correct?
That's correct. And other permitted uses under HIPAA.
Okay, and can you tell the committee, just to refresh our memory, what House Bill 1022 was? Whether you or David could do that, I appreciate it.
So I see David has gotten up.
And I hate to put you on the spot, but if we're going to vote to clean something up, just to refresh our memory of what it is, you know, I know, I'm a senior citizen, can retain a lot up here sometimes.
So prior to the adoption of 1022, CRISP had adopted a consent registry. Recall that in Maryland, we are an opt-out state for exchanging information through the state designated health information exchange, and approximately 10,000 residents of the state opt out. But we also, in discussions with privacy representatives and consumers, concluded there was misunderstanding about what that consent registry consent actually did. And consequently, we concluded that, well, many consumers thought they were opting out of all health information exchange in the state. They were only opting out of exchange through CRISP. 1022 went back and corrected that by providing a framework through which consumers could opt out of most health information exchange. Keep in mind that even with 1022, they can opt out of the prescription drug monitoring functions that are important for monitoring the use of controlled substances such as opioids. They can't opt out of that, but they could through 1022 opt out of all information exchange, which is what consumers believed they were doing previously when they through contact, through CRISP, through emails, through phone calls, or through communications, said they wished to opt out of CRISP. Most consumers thought they were opting out of everything. 1022 activated that, but what we pointed out is to make that effective, we needed to include all entities that performed health information exchange, which included health included not only the traditional health information exchanges, but the electronic health records that vendors that have become extremely prominent and offer much of the same functionality as is available through traditional HIEs.
Okay, beautiful.
Can I
Thank
clarify
you.
something just real quick? In case anyone was looking up, it was actually House Bill 1375.
Excuse me.
1022 was your other bill.
That is wonderful. That helps a lot. So, okay, and it happens, Ben. House Bill 1375 is the bill that we passed last year that allows everyone to opt out on all information exchange. And this one right here basically defines the definition of what a health information exchange is. Are there any questions now from the committee members? I have Delegate Shalega.
Thank you, and sorry, my computer froze, so you may have answered this question while I was rebooting my computer and getting back on.
It's okay. Yeah.
I hate that we're not in person.
I know, it's such a disconnect, right?
In real life, if I was sitting in a room with you, I wouldn't have to reboot you. So I'm sorry to look over here, but Ben, did you talk about the information that came from the Office of the Attorney General? Specifically, they said, we understand that EHR vendors are monetizing patient data. I'm a little concerned about monetizing patient data, and I'm extremely concerned about privacy. And, you know, if somebody gets a hold of your electronic health record, it has everything on there someone needs to steal your identity, your name, your social, your birthday, your address. And besides the fact it has all your personal health information on there as well. So very concerned. What can you tell us about that?
So, I mean, I think we have to be, this specifically doesn't prohibit the health information exchange for using it for permitted purposes. This would enable consumers to prohibit exchange of information with an opt-out from having that information shared. Health information exchanges through both federal and state regulation are pretty strictly limited in how they can use health information exchange for treatment purposes. And the monetization of information does occur, but I'm not aware of that occurring through at all through CRISP, as they are restricted through both state and federal regulations, as well as corporate business practices. In terms of the commercial HIEs, they would be limited by state law if they are covered by this, as well as by federal protections to the extent they exist.
Did you work, has the Attorney General, it says, we have been working on the bill over the last few days with the Maryland Healthcare Commission, look forward to continuing that work in subcommittee. So are you here in subcommittee, Office of the Attorney General? And what do you have to say, please?
And they're here. And
Good.
will you please speak up? Pat O'Connor, I imagine, right?
I see her name.
Thank
There
you.
she
Beautiful.
For the record. How are
Yes.
you, Delegate? How are you, committee members, Chair?
Thank
Nice
you.
to see you. Thank you for raising the topic. We have been discussing
Can't come
a
up.
lot of our concerns about privacy and about uses of de-identified information and simply the lack of information or transparency regarding how health information is being exchanged outside of the entities we're addressing here in this bill, and sometimes via the entities we're addressing here in this bill. It's probably not possible to fully engage on that serious concern today or through this bill, but we really think it is important to include, and I just want to point out that we have one way we want to try to maximize protection for Marylanders. I'm not sure if it made it into the document that the subcommittee is working from. What I have is a document that David and Ben provided to us within the last hour, and we were exchanging some comments. And that document still contained strategically placed language where we say, to the extent preempted by federal law, and then it follows what this provision by provision says. We think that is really important language because it will allow Maryland to exercise as much state regulation as possible, in addition to federal regulation on these issues. And so as a matter of drafting, we would really appreciate the courtesy of seeing the document, just checking the placement of those provisions. We also are hoping that the commission will be able to look at the issues that we're raising. Our concerns really arise out of what we are hearing about with carriers in other states, right? And so it is our understanding that there are some of these uses being made of health information, and we don't know the specifics. We're not certainly in a position to make any accusations. We, though, are concerned that there appear to be entities affiliated with carriers doing business nationwide, doing business, it appears perhaps in our state, where there are where the data appears to be monetized. And this is something that is bubbling up in the literature. We're concerned about it. We want to be sure through this bill, we preserve the ability of our state, to the extent it's not preempted by federal law, to retain the ability to regulate as fully as possible in this space.
And we would be fine with, to the extent not preempted language. I think the question is, we would work with committee counsel on where that should be placed in the draft. I think that's the question. It's repeated what we were not able to get in touch with our colleagues at HEAU, but we think it probably could be placed in one place and would accomplish exactly what they intend to.
So I know we have another question. So what I want to do is I want to hold the bill and give you and Pat O'Connor an opportunity, and David Sharp, to work on the language and let Erin know, bring her in where that can be put in, okay? We have, and thank you, Delegate Shalega, for your question and concerns. I think it's a very good one. Delegate Hill, your question?
Thank you, Madam Chair. So if it's going to be held, would you prefer for me to ask to speak with either David or Ben separately about my questions?
We're in the hearing, we're in the
Okay.
subcommittee
So,
now, so ask your question.
All right, thanks, Ben, for that explanation. I just want to be clear about a couple of things. So this amendment separates a definition of the health information exchange and the health information developer consistent with federal definitions, but they are both still covered under the same opt-out, or one is covered and one's not?
They are both covered.
Okay. And the exception, as I read it and read through the amendment, is still entities, practitioners who, for billing purposes, are communicating with one another. So people can't opt out of that. Is that a correct understanding?
So entities such as that are covered under federal HIPAA regulations are stated as not being health information exchange because they are covered as HIPAA entities, not as an HIE. So that includes health systems, healthcare payers, and specific healthcare providers, and entities that are working on behalf of those covered entities, business
Right.
associates.
Okay. So, but you also have additional language in here on page 2 that says that, and that's just clarifying language, and that is for treatment, payment, or healthcare operations purpose, or those terms are defined. So you're just referencing that, but you're stating it too.
We're referencing the purposes for which they are exempt.
Okay. Okay. And does this cover only entities that somehow communicate with government-run HIEs or the exchange, or is this also for private entities that have no connection at all to ours? So no matter what insurance, or if people are having no, like HIPAA excludes people who aren't paying through insurance. Those practitioners who don't bill and do insurance, they're not covered under HIPAA. So is that every entity, and no matter what healthcare exchange in the state, or are there certain things that are not covered under this bill? Just like when we do insurance, there are certain insurance companies that we just don't get with our insurance business.
So the HIEs typically would be exchanging clinical information, not administrative business information, and we don't. Our intent is to cover all entities that perform the functions of a health information exchange.
And this is the opt-out for both.
Regardless of whether a patient is insured or uninsured, or covered by a government insurer or a private insurer.
Okay, and then the last question is, when a person opts out, will they have a choice of opting out of both identified and de-identified information, or once they opt out, they're opting out of any use and sharing of their information at all?
The intent is to allow consumers to opt out of information for research purposes, if that's what they want to limit their opt-out to, or for all information, if that's their choice. Keep in mind that we are somewhat marching along the pathway of what technology can allow us to do. And we expect that as capabilities of electronic systems advance, we will be coming back to you to gain some additional authority to make opt-out even more selective, but that is not possible at this time.
Okay, and then I guess there is one more question. So someone opts out on this big common button, and then they see their individual practitioner who wants to go on to CRISP and get their medical records, and they want to give that particular individual practitioner permission to do that. Once they've opted out, is it all or none? I'm out of everybody, or I can individually opt into individuals and they won't be out of compliance or in violation of the law?
So we're working through those particular scenarios with the technology firms right now. I think that what I would say that initially we're going to have to provide for greater sledgehammer type approaches, but the ultimate goal is to be as selective as patients desire their information sharing to be.
All right, thank you. Thank you, Madam Chair.
My pleasure. Any other questions? Delegate Riley? You're muted.
Sorry, thank
It's
you.
okay.
Thanks, Madam Chair. Yes, after listening to Delegate Hill, just some clarification. So every time you go to one of your physicians, so every single one of them, like all of the offices, you have to opt out?
No, that's
Or
the
is it
approach.
one-
Excuse me, Delegate. So that is the approach today. What we're trying to accomplish for those consumers that want broad opt-out, the ability to opt out entirely. The understanding in the marketplace today is when I go to CRISP, I'm opting out of everything. That's not in reality what's happening. If you want to opt out entirely, you would have to visit potentially up to 11 different HIEs and opt out. What we intend to do initially is to make that global opt out the standard that patients would achieve by opting out at any particular HIE that they come in contact with.
Okay, just Madam Chair, could I have follow up? Yes.
Sure.
Thank you. So when you say the HIEs, just to understand this, because you said the CRISP system, so not all providers, many providers have their own healthcare system that you can actually apply to, sign up to, and you can see your health records and everything online. Now, is that an HIE, that online visual that you can look at and you give the approval? Like for me, for instance, I opted out and I can't see mine online at all for any of my physicians, but yet my husband does, and we can see his. So is that something that, that you're talking about here in this bill?
So if
That they can't share that?
From an individual provider, you could see that, but from that provider, let's say your husband had a urologist and a family medicine provider. If he opted out, he wouldn't be able to see the information from one provider to the other when he was viewing the records at his, say, the general practitioner's web portal. That would be if he opted out.
Okay. All right. So if he didn't opt out, so that particular system is an HIE. So like MedStar has their own, University of Maryland has their own. So all of these are grouped into this bill.
So it's not probably what we should say is that University of Maryland uses the EPIC EHR system, and EPIC meets the definition of an HIE and does offer those interoperability features. You could, within the EPIC system, without opting out, see your information that was held by OMS. But if you opted out, you wouldn't be able to see the information held by and say Anne Arundel Medical System, which also uses Epic.
Okay. Is there any way, could you have a list, or was that in our, maybe in the fiscal note? Is there a list of the HIEs that are under this bill?
So the I think I'll yield to David Sharp if he can, if his microphone is on, to name them. But really, there are two groups that we are intent on including in this legislation: the physical HIEs, the CRISP, the Adventist, et cetera, and then the HIEs that behave.
Dave is on.
David, are you on?
Yeah, he's
Yes,
on.
I'm here.
Go ahead, David.
Go ahead, David.
So so just to be clear, what Ben is saying is today there are 11 organizations that meet the existing definition. Once the definition is changed, it brings into the fold other types of vendors that Ben is describing that would now would fall under the existing regulations around privacy and security that the AAG, Pat O'Connor, is talking about, which would then also address the information sharing capabilities. So the current list, I'll just read it off, includes a couple health systems, one being Adventist Healthcare, Allscripts, Audacious Inquiry, Cerner, which is MedStar's solution that Ben mentioned, CRISP, which everyone here is familiar with, Children's IQ Network, Collective Medical, eClinical Works, Epic, NextGen, Scintillas, and SureScripts. And as I mentioned, there are a few others that would come under the definition when it's changed because they're considered to be the software developers recognized by the Office of the National Coordinator for developing these modules. Essentially, it's an EHR vendor who has an interoperable system, if you will.
All right, thank you.
So right now you have 11 entities that are recognized as HIE, but once this definition is changed, then you will have everyone out there will fall under this definition. Is that correct? And people cannot opt out of everything, as opposed to presently, you will have to go through all those 11, right?
Correct.
But this definition and this change would allow you to do it once, hopefully.
Through the consent management utility that you all passed last session.
And that goes into effect when?
So the bill went into effect last year. Right now, as our executive director mentioned, we're working with the technology components and the vendor to put in place that technology.
Okay. Can you send us that list, please, to the committee? Send it to Erin, and Erin will send it to all of us.
Sure, happy to do so.
Thank you so much. I appreciate you, David. I have Delegate Kelly.
Sorry, I was putting my hand up and down because I'm just getting all these different texts. I just wanted to make sure, since David is back now, I think that part of what Pat was discussing as her concerns is included in the language in the amendment we have. And I think I'm just being told that maybe David has the answer to that. I'm just trying to get that clarification for the subcommittee, but it can certainly wait if we want to take it up another time. I just think there was maybe a little circular communication going on in that part. Because as I understood it, the amendment language that we have before us does include the concern that Pat was raising.
She says she hasn't seen it and hasn't read it. So Pat, can you look at that?
Absolutely. And I got a message from Tracy DeShields, who works with Ben and David, and she says the copy we have is the copy you have. So if we can confirm that, just because there have been a lot of copies passed around, and that would be important.
And I think it's helpful to know the twofold piece here. One is the language to the extent specifically preempted by federal law. I think that's partly what Pat's suggesting. And as our executive director noted, he would like to work with Pat and Erin to look at the placement of it. It isn't so much the concern about the wording, it's just, is it better to place it in one location or in 3 locations? So I think that's not really much of a stumbling block. The other concern that I thought I heard Pat mention was that the issues related to privacy and security for organizations that are functioning as an HIE who are outside of the definition of an HIE. And that is in part, as our executive director noted, the cleanup work from last year's bill that we spent a lot of time during the recess session to make sure that we identified where there are challenges, and by aligning it with the Office of the National Coordinator's definition, the federal definition, particularly around health IT developers, it addresses the concern of ensuring that organizations who are functioning in the HIE space in Maryland now would be subject to the same definition that, say, CRISP would be in Maryland. So at the end of the day, it's actually it adds tremendous value, and it also is very consumer focused because it gives consumers, as we heard a couple of the delegates note, wanting to be able to go to one place to opt out to make sure we get to all those organizations who are sharing information. And that way we become more what we might say consumer friendly, and it becomes less onerous for consumers to opt out.
Okay, so what I'm hearing is, and thank you, David, what I'm hearing, Delegate Kelly, is that David and Pat would like some time to work with Aaron to figure out where to put that federal language, whether it's in one section, section 2 or 3. So there seems to be consensus on what the bill does and on the amendments, but there is not consensus on where to put it in the bill. And they want to work with council, okay? So what we're gonna do is we're gonna hold it so that my instructions will be for David, for Pat and Ben to work with Aaron as to where to put that language. And then when the bill comes back on Monday, we will get it already finalized because Pat, there's agreement and you said, you agree with that language, so that should not be revisited. It's just a matter of where it goes in the bill. Is that your understanding? Does that work?
We're fine with that.
Okay, beautiful. Delegate Kelly?
Perfect plan. Thank you so much, Madam Chairman.
Thank you. And Aaron, is that okay with you?
Of course, yes.
Okay, and Dr. Hill, Delegate Hill, do you have a question?
Maybe you can wait till next Monday or they can talk to me offline. We've been talking about what this does. What I'm really struggling with is if a person opts out, I'd like to know if they go to see their doctor, they get an X-ray at advanced radiology, they get a COVID test through CVS. Does that mean the practitioner can no longer share information at all? And so how does the practitioner then get the lab results, et cetera, for someone who's opted out?
Who can answer that question? And while we're at it, let's just answer it so we're not, next week, we don't start anew. Let's just try to iron this out right now.
David, do you want to answer that?
Sure. So lab data, Dr. Hill, you would still receive. Opting out doesn't limit information that you would need for treatment such as labs or radiology. The opt-out would be that from one provider to the next provider. Let's say I didn't, as Ben noted in an example, I didn't want a certain physician to see information from my primary care provider. So I would opt out. And that way, what the provider would see is an indication that I've opted out. And it allows the provider to say to the patient, hey, I see there's information here that you don't want shared. I just want you to know that and explain the rationale for maybe why that patient needs to share it directly with them. Information can be shared between providers. This is just the electronic access of that information.
Right.
So I think, Dr. Hill, to your point, it would not prevent you from having access to radiology reports or to lab data that you need for care delivery.
So that is not considered under either HIE or a developer?
It is not.
The software they use is not covered.
That's correct.
And if someone's opt out and I do want my information from Dr. Bagnall, then I have to go back to faxing or mailing because the person's opted out of her sending it to me through electronic connection?
you could use other electronic means, but I think you understand the way you've characterized it is correct.
Okay, all right, thank you.
Any other questions while we're here? This is the time. We have everyone at the table. Okay, does everyone, you guys feel comfortable doing what we plan? Okay, so we're going to hold it and we're going to come back on Monday. Meanwhile, I expect the parties that were just mentioned to get together and work it out, okay? Where the placement of the language goes. I want to thank you guys for coming and for your patience while the committee worked through the questions. It's an important bill, and especially to our constituents, so I really appreciate everyone's input. And Delegate Kelly, thank you for being with us today. I appreciate you. Now we're going to go on to our next bill. So we're going to hold House Bill 213, and we are going to go now to the following bill, which will be House Bill 287, the Secretary of Health, Qualification and Requirements. Erin, can you tell us what the bill does, please?
This bill requires the Secretary of Health to be professionally qualified through experience or education in at least one of the following areas: health law or policy, healthcare facilities administration, health economics or financial management, government operations related to healthcare, or as a healthcare provider.
Thank you. And when we had the hearing last, there was a question asked as to were there any other secretaries that had required experience. So in our research, we found out that the Secretary of Budget and Management must have experience in public financing, budgeting, management, and fiscal planning. The Secretary of Disabilities must have extensive experience with knowledge of disability law, legislation, and regulation, and programs for individuals with disabilities. It says at a minimum hold a bachelor's degree and be an individual with a disability, or appoint a deputy secretary who's an individual with a disability. The state superintendent of schools says they must be an experienced and competent educator, be a graduate of accredited college or university, have at least 2 years of special academic and professional graduate preparation in an accredited college or university, and have at least 7 years of experience in teaching and administration. The Secretary of Information Technology says that they have to have experience in information technology, data processing, telecommunication, and system procurement, planning and management. So basically, you know, this is not, this has been done, and this is for the Secretary of Health. As you know, we are living in a pandemic for almost 3 years now, and our public health system, we need to really have all hands on deck. And that is basically the reason for the bill. The bill does not, so that we're clear, actually does not affect the current secretary. It will be for the next administration. And so that we're clear as well, respectfully, the bill does not take the right of the governor to appoint. It is still the governor's appointment. It just basically has an education requirement. And that is what we have. Are there any questions from any of the members? Delegate Chisholm.
Thank you, Madam Chair.
My pleasure.
Dylan, and I don't know if Dylan shared this with the rest of the committee, I did ask about other states, and Dylan did a really nice job of putting together all 50 states and what they do. I noticed that the vast majority of states, without me counting, do have a physician as part of their requirement. I know we're not going that far. And I guess I'm just going to ask you, Madam Chair, since
Yes.
Did you consider that, or do you think the educational requirement will suffice?
I consider it. However, the definition says it can be a provider, which means that it could be a doctor. So it's just one of the options. The reason why I didn't do that is because I didn't want to be that prescriptive as well, because there are people that have masters in health, PhDs in health, and they have the background to bring that public health background. I just didn't want to be that prescriptive.
Okay, I was just curious because I do like the intent of the bill.
Yes.
I also like physicians that have actually practiced in the field, but I just figured I'd ask you that. But thank you very much.
No, thank you for your question. I appreciate you. Any other questions or concerns? All right, seeing none, may I have a motion on the bill?
Move the bill.
Second.
It's been moved in second. Are there any discussions or concerns? Seeing none, all those in favor say aye.
Aye.
Anyone opposing the bill? Seeing none, the bill passes. Thank you so much for your questions and thank you for the conversation. Next, we have our last bill of the day. It's the third bill, is Delegate Rosenberg, House Bill 297, and it's actually titled Facilities, Disabilities, Juvenile Behavioral Health and Healthcare Safety Plans. Erin, can you tell us what the bill proposes to do, please? You're muted. It's okay.
Yeah.
My pleasure.
The bill requires facilities for juveniles, state residential centers, private group homes, behavioral health programs, and healthcare facilities such as hospitals, nursing homes, and assisted living facilities to establish a safety plan, that is, if they have not already required to have one, and to revise that plan every 5 years. There is a reprint of the bill that's been provided that incorporates some of the amendments that were proposed at the bill hearing. One of those amendments is that the 5-year requirement be modified to state not less than every 5 years. And it also authorizes the facilities to implement a safety or emergency plan that has been established for another purpose. If you look on the reprint on page 4 after line 15, this would add sex offender rehabilitation providers to the bill, and it would subject them to the same requirements regarding the establishment and revision of safety plans. Then there's also a separate amendment that's not part of the reprint, and that would require that the regulations related to the requirements for licensure as a behavioral health program would include a statement certifying compliance with certain national fire protection standards.
Thank you, Erin. Delegate Rosenberg.
Thank you, Madam Chair.
My pleasure.
This bill is modeled upon or builds upon legislation which we passed last year, Senator McRae's Senate Bill 96, which established these requirements with regard to a safety plan for behavioral health facilities. And as Council Aaron Hopwood has described, this bill would extend that requirement to developmental disabilities facilities, juvenile services. That was in the bill as introduced. The amendment before us would also extend it to any entity where the majority of its clients it serves are sex offenders. And the bill would also provide for flexibility with regard to the safety plan in two instances. One, that if it is submitted, it had already been submitted for under another requirement of law or some other national organization, that would be sufficient. And then that the updating could be within 5 years, doesn't have to be every 5 years, because there's some existing requirement for a safety plan. So we're not imposing an additional burden on these providers, but consistent with the Fair Housing Act, because last year's bill was obviously reviewed by the Attorney General's office. This bill would provide that protection for people who are served by other facilities, juvenile justice, juvenile services, developmental disability, and sex offender.
1 second. So last year we passed 96, which requires a safety plan for behavioral health program. This year, this bill is expanding it to residential centers and group homes to serve juveniles and persons with disabilities, correct?
Yes, but under the amendment, it would also extend it to sex facilities where a majority of the licensees' clients are sex offenders. That is an amendment that is before the committee now. It was not part of the bill hearing, just to be very open.
Okay, no, I appreciate it. Let me open it up to our members. Are there any questions? I see Delegate Hill, followed by Delegate Bagnell and
Thank you.
Delegate Shalega.
Thank you very much. Delegate Rosenberg, really appreciate this. I'm assuming a safety plan, generally speaking, would be one that ensures not just the resident safety from adults and caretakers and folks in the place, but also for other residents. In the amendment that talks about facilities that have a majority of residents who are sex offenders, it talks about a safety plan that protects them, which is important, but is it not necessary, or is it covered under the rest of the bill that that safety plan should also protect any, since it's the majority, any of the other clients who are not sex offenders, that basically all the youth need to be protected, both as being prey and from potential, predators or whatever. Are both protected here when it says it simply has to establish a plan that protects them, the sex offender?
Well, the language in the bill is introduced, and I don't think there's certainly no intent to change that. Says that each state residential center shall establish and implement a safety plan for the safety of the individuals served by the state residential center. And correct me if I'm wrong here. Aaron, we don't tinker with that, do we?
No, but I don't think that's what she was asking about. I think, Delegate Hill, are you asking in particular to the sex offender rehabilitation program?
Yeah, in other words, I think Delegate Roosevelt partially answered. He said that we're generally saying that residents need to be protected. We then add this different section to make sure that clients who are in a facility that primarily caters to people who are sex offenders, that the sex offender clients are also protected.
Correct.
Since we're making that distinction, in that environment, do we need to make sure that the non-sex offender clients in that environment are also covered under the safety plan? Or is that covered under the language that Delegate Rosenberg just talked about?
I see.
Yeah, that's the question.
Not explicitly, I don't think. I think you could add to that particular section of the sex offender provider.
Mhm.
I agree.
Say that you could implement a safety plan for the safety of the sex offenders treated by the sex offender program, and then also the other residents.
Thank you. That would be great.
Thank you.
Thank you.
Thank you.
Okay, Delegate Bagnell, followed by Delegate Shalega.
Thank you so much, Madam Chair.
My pleasure.
Just to clarify again, because we're just seeing this amendment, because the overall bill refers to juvenile services, the sex offenders portion, does that specifically refer to juvenile service providers for sex offenders, or is it a broadening in that section of the bill?
It broadens who is covered, but the language explicitly refers to and says sex offender has the meaning stated in 11-701 of the criminal procedure article. So we're not tinkering with the definition. We're broadening the bill and this safety requirement to include sex offenders and others in the facility, as we just agreed to do.
We just discussed. Thank you so much.
Sure, thank you.
Delegate Shalega.
Thank you. This does seem like a big change, and I may ask to hold it so that we can take a look at it. Once you put sex offenders in there, we need to make sure people have had a chance to look at it and weigh in. But I see in the bill other provisions for the safety plan, including the community around or at large, and I don't see that in the sex offender language. Am I missing it? Erin's shaking her head. And I'm sorry for the music.
It's not in there.
It's
You're
my
correct.
daughter, my granddaughter, if you hear Tweety Bird.
That's okay.
It's kind of the same issue Delegate Hill raised, where if you wanted to clarify the provisions of the safety plan, that could be added.
Yeah, I'm not sure we're ready to add sex offenders to a bill that didn't start out with that, where we had an adequate amount of input. And so would ask the maker of the bill, the Delegate Rosenberg, to consider maybe putting in a separate bill for this, or minimally giving us another week to look at it.
I'm fine with another week. And I, just some implicit or raise that point at the outset by saying this is language that was not in the bill as introduced or in an amendment before the committee hearing. So I am fine with a week's delay.
I have to say, I was, before Delegate Shalega raised her question, I was thinking, Delegate Rosenberg, that I'm going to hold the bill and that I'd like you to reconsider that language. And we can talk offline. I'm curious where it came from, but if we could talk offline. But you know, the bill without the language was pretty good and solid, and I can see why it was needed. But this added language was not included in the hearing, and the members didn't have an opportunity to ask questions or listen to it. So there's no rush. We just started. So if you could take a week and let the members think about it. But most importantly, I want you to reconsider that language if you can, because you can hear the concerns of the members, okay?
Okay, fine.
My pleasure. Thank you, Delegate Shalega. That's a great point. And Delegate Hill. Any other questions or concerns that you may have today? Okay, great. So I want to thank Erin for sending us the agenda. She will continue to send us the agenda for the Monday. Please check the link, and thank you so much for coming on time. And she'll let us know what's next. You know, the bills, our public health bills are heard on Wednesdays. So those are usually the bills that will come the following Monday, more or less, some of them. So if you have any questions, please call my cell phone. If you have any questions about a bill, you want to hold it, or whatever the question may be, feel free to call my cell phone. I look forward to seeing you with this subcommittee next Monday. Thank you, Erin, and thank you, Edith. Have a blessed day, guys.
Bye-bye.
Bye. Thank you.
Bye-bye.